Topf with Nephrology Times, and I've got Dr. Singh and Dr. Turner here, and they're from a company called Renibus, and they hold Vivaramir, which we last saw in the CKD VALOR trial, which was published in JASN a handful of months ago. And this is a treatment for metabolic acidosis. Why don't you tell us a little bit about Vivaramir?
You can talk about that.
So Vivaramir is a polymer that absorbs hydrochloric acid in the GI and raises serum bicarb levels. So it's being developed as a treatment for metabolic acidosis and CKD.
Right, so metabolic acidosis, it recently has taken kind of a hit because the most recent KDIGO guidelines, in the 2012 form, it was, I don't know, a 1B or something, but we were all supposed to treat metabolic acidosis to 22, and now it's just a practice point. It no longer is one of the guidelines. And that kind of represents kind of the soft data that we've seen up to now?
Yeah, exactly. I mean, there's obviously very clear evidence showing the association between low serum bicarbonate and negative outcomes.
And progression, progression CKD.
But the challenge is showing that improving or increasing serum bicarb leads to better outcomes. And the studies with oral alkali have been a little bit unclear for one reason or another, the dose, the type of patients.
Blinding.
So yeah,
that's
exactly.
a big issue there.
Yeah, so,
right, because this was, in the phase 2 trial of Vivaramir, they had spectacular data that it was unique, because it was not completely unique, but largely unique, that it was blinded data showing pretty significant improvement in outcomes with improvement in metabolic acidosis, and then they kind of stumbled. And I think a lot of people recognize that in the CKD VALOR, there wasn't good separation between people on placebo and people on drug, and you need to see separation in the bicarbs there to show a difference, and that wasn't there. You guys have any thoughts on why they didn't get that separation there?
Yeah, if you look at the placebo subtracted bicarb increase with Vivaramir in the VALOR study, it's about 1.3.
Okay,
which is
1.2 too small.
Very too small. And that's probably the issue with some of the alkali trials as well recently.
Yeah, there was the transplant one, same issue.
Same thing, and the bicarb study, same thing. There's lack of separation. So if you're not getting to a goal that you established as the optimum bicarb level, you're not going to translate that into outcomes. Now, the next question is, why did that happen? Why didn't the patients respond? Or why was there a response over time? That is very difficult to tell. It could be a dosing issue, it could be a dose frequency issue. Those are some of the questions that we want to answer so that we pick the right dose as we move forward with the development of this drug. So we don't have the right answers to that right now, but we know for sure that if we were able to achieve the bicarb levels as we desire to, I think the guidelines will revert back to where the bicarb should change. That's what we think will happen.
And so you're releasing some new data now. This is kind of the first data since we had the CKD VALOR. And so what were you looking at in this study?
So when we looked at the VALOR CKD and there was lack of separation of bicarb, we said, okay, so it looks like Vivaramir and placebo are basically the same for bicarb increase. So if that's the case, let's take these 1,500 patients and look at their bicarb levels over time, and whether they reached a certain target, let's say greater than 22, or they stayed between 20 to 22, or stayed below 20 over the 2-year period.
So it's just achieved bicarb.
Achieved bicarb, and whether that translated into outcomes. And we are presenting that data at NKF.
And don't leave me hanging. Did it translate into outcomes?
So maybe you can talk about that.
So it's very exciting data because it's a prospective study. It's not retrospective.
And
when we looked at the achieved serum bicarbs over 3 years, and then we looked at the CKD outcomes in those patients that achieved the highest level, so a serum bicarb greater than 22 versus less than 20, for example, there was a clear difference in terms of CKD outcomes. For those patients that had an increase of 4 milliequivalents per liter serum bicarb versus only 2, there was a clear difference in terms of CKD outcomes. So it's really exciting data to show the potential link between improvements in serum bicarb and CKD outcomes. Now, as Bhupinder said, regardless of treatment. So obviously we still, in terms of Vivaramir, we've got some extra work to be done, but it's actually very nice proof of concept, the link between raising serum bicarb and improving CKD outcomes.
And maybe, Stewart, you could talk about the Vivaramir subgroup where the patients went above 22 compared to patients who stayed below 20.
Yeah, so interesting, it's in the poster that when we, even though we did it regardless of treatment, we did look at Vivarium versus placebo, and in the Vivarium group, there actually was a significant improvement in outcomes in those that reached the target versus didn't reach the target. So greater than 22 versus less than 20. That wasn't the analysis that was done in the trial.
Subgroup that had improvement in bicarb and were on Vivarium, they did better. They had fewer outcomes.
And they had the lowest event rate of all other subgroups. So if you look at 6 subgroups, that was the best.
So, it's very intriguing.
So if you squint your eyes and look out of the corner, you can kind of see there's a signal of efficacy there. It's a thread to pull on at least.
And what we want to do now as next step is we take that subgroup of greater than 22 and see if there is an optimum bicarb that can be established. I don't know how many patients we have in that, but if you separate them to 22 to 24, 24 to 26, or greater than 24, and see if at 24 you're getting the best outcomes compared to 22. So that'll be another question we want to answer.
And that's also information that's in CKD Valor.
Yes.
And how long before you guys are going to start generating your own data? Is it really going out and using this drug?
So we are right now planning to meet with the FDA to start the dialogue with the FDA, like a pre-IND meeting where we discuss, okay, here are the possibilities we have, the clinical development plan. In that, what we want to do is first establish the dose, frequency, relationship to the meals. Of course, Tricida did some of that work. We want to do a little bit more than that. So we want to really find, okay, so 9 gram was the maximum dose in VALOR-CKD.
Okay.
86% of the patients achieved 9 gram, which tells us that maybe there is room there.
Yeah.
Almost everybody required.
Everybody was on the maximum dose.
Maximum dose.
Maybe
the
that's
dose
not
was
enough.
6 grams twice a day might have been the optimum dose to get you that separation. So we want to study that sometime this year once we have a dialogue with the FDA, and then we'll start building upon that in terms of indications. We are a small company, we don't have resources to do a CKD outcomes trial, but we want to do a trial where we can establish a surrogate of outcomes along with the bicarb improvement. So whatever that may be, that's a discussion to be had with the FDA.
Oh, that sounds exciting.
And coming back to what you said at the start about the KD goal, we recognize where the guidelines are, but certainly when we talk to the nephrology community, as we are at this Congress, and I'm sure as you're aware, the clinicians want to treat. If a serum bicarb is less than 18, they're interested in
You
treatment.
have a whole cohort of nephrologists that for 10 years have been told that this is what you need to do. Yes, everybody wants to treat because that's how they've been trained. Honestly, now that it's out of the guidelines, that's going to ease up your ability to do a placebo-controlled trial. Like, it's really difficult to do a trial when the guideline says you got to treat it,
Well, that's
right?
been the challenge with the oral alkali studies, because we've heard that from investigators. Their ethical committee wouldn't let them study patients with serum bicarbs less than 20 in a placebo-controlled trial.
Because the guidelines say. And
so it'll be interesting.
You actually have a little more latitude. That actually may, funny, in a strange way, that may end up working for you. Hey, good luck. I would love to have another effective therapy. And it's funny, especially an effective therapy for people, and I hate to use words like, but at the end of the roadmap. Like, so much of our therapy is focused at GFRs of 60 and high functioning, and this is actually, no, let's look at the other end. Can we extend their time before dialysis and maybe allow them to get a primary transplant, if you can delay that for a few years. Hey, thanks. Good luck to both you guys.
Thank you. Bye.